Welcome to Dalela Euro Academy. You have chosen to know something about anuria and you wish to know how much and in what way you should approach a patient who is suffering from anuria. With this presentation, I'll share with you some information. Let's see first of all, what is this entity, anuria? Anuria is defined as a clinical condition when in adult the urinary output is less than 50 ml per day. This condition is a life-threatening condition and it can kill the patient. It can kill in a matter of seconds and it kills sometimes silently. There are some related definitions which you should also know at this stage. One word is called oliguria, which means that the 24 hours urinary output in adult is less than 500 milliliter. There is also a word not so commonly used is non-oliguria. Here the urinary output is more than 500 ml, but patient systemically is having acute or chronic azotemia. There is a word which is sometimes used by clinicians, not in written text so much, and this is absolute anuria. There is total and complete absence of urine output. Your patient may be having, any of these few combinations. We are going to talk about the clinical approach to a case who is having anuria. As you do in any emergency, here also you should follow a step care approach. The step care approach means you go step by step. The first step, you confirm the presence or the existence of the problem. You must make sure that when your patient is saying that I am not passing any urine, you must make sure that is it actually anuria or is it something else. If it is anuria, your next step should be immediately to find out is the life of the patient at risk. If it is at risk, you forget everything else and first manage the problem. Save the patient, that's the priority. If your patient is safe and if your patient is stable, then you can give time to find out what is the cause of anuria. And the next step would be to manage the cause which is leading to anuria. And the finally step would be to prevent the recurrence of anuria. If anybody who has had anuria once, treated properly, should not be allowed to have this again. So from now on, I'll elaborate these steps one by one to you. First of all, let's see how do we find out, or let's see why at all this question, is it really anuria? The patient says, doctor, I have not passed urine since, let's say, so many hours, or let's say 2 days, I have not passed urine. When patient says, I have not passed urine, you should assess whether it is anuria, right? In this anuria, because kidneys are not producing urine, you will have no urine in bladder or very minimal urine in the bladder. Bladder is empty. But there is another condition where patients develop urinary retention, and there also they say they have not passed urine. Here the bladder is full of urine. So you must see that there is a difference in the two scenarios. Common thing to both is they are not passed urine. In one the bladder is empty and in the other the bladder is full. To differentiate what is happening in the patient, is this a case of anuria or is this a case of retention, you have to follow the rule of 3S. there are three differentiating symptoms. First symptom is desire to void. In anuria, because the bladder is empty, the patient will not have desire to void. In retention of urine, patient will have excessive desire to void because bladder is overfull. Second symptom is pain. The bladder is not full in anuria, so there is no suprapubic pain. But in case of urinary retention, patient has progressively increasing suprapubic pain. And third is the symptoms of renal failure. In anuria, you will have symptoms of renal failure, and the severity of symptoms will depend upon the duration of anuria. You can have features of volume overload, you can have features of nausea, vomiting, anorexia, and you can have a variable degree of somnolence. All these are mostly absent in a patient of acute urinary retention. So you concentrate on three symptoms and ask from the patient. You will have three differentiating signs. You percuss for the bladder. In anuria, it is not there. In acute retention, it is full and it is percussible. Look for renal tenderness. In anuria, it may be present. In some patients of anuria who are having obstructive anuria, you can have renal tenderness. But in patients of urinary retention, there is no reason for you to have renal tenderness. The third thing would be to have features of the cause of anuria. In an anuria setting, you have shock in those patients who are having pre-renal anuria. You can have hypertension in those patients who have renal anuria, and you can have flank tenderness in those patients who have post-renal anuria. So depending upon what is the cause of anuria, you can have a feature of the cause on examination. Same way, in the patient of acute urinary retention, you can detect on examination feature of the cause. Say for instance, you may be able to palpate a stricture. You may be able to palpate an enlarged prostate, or you may be able to digitally palpate a prostatic cancer nodule. So you can have some finding on examination. You have three differentiating tests. You can perform ultrasound of the bladder. In anuria, this is empty bladder. In acute retention, this is full bladder. The renal functions, the serum creatinine, uric acid, potassium, they are usually deranged in anuria, but they are mostly normal in a patient of acute urinary retention. And finally, the gold test. On passing a catheter, no urine comes out or few drops come out in anuria, and in acute retention, you drain whole lot. Having decided that your patient is having anuria and not urinary retention, this is a more serious problem, because if neglected, it has potential to kill the patient. You have to know these killers. What are the killers in anuria? You have to learn to identify these killers in anuria. You have to then learn how to quickly treat these killers. So you follow this approach, KIT approach, and let's see the killers. These killers are hyperkalemia, presence of sepsis, and presence of fluid overload. How can you identify hyperkalemia? Clinical feature wise, mostly there is no clinical symptom or sign of hyperkalemia. You should not expect anything. But sometimes you have a dominant picture of metabolic acidosis, patient is hyperventilating, patient is restless. In that scenario, you should strongly suspect hyperkalemia. Otherwise, there is no specific feature of hyperkalemia. Investigation wise, you should check serum potassium. If it is more than 5, suspect hyperkalemia. and immediately substantiate this with ECG. ECG will show you tall T waves. If it is more severe hyperkalemia, it will show you prolongation of PR and QRS duration. If it is still more severe, it will show you loss of P waves. If it is still more severe, it can show you, a sine wave pattern or something like ventricular fibrillation. So by investigation, you should confirm that the patient is having hyperkalemia. The second killer is sepsis. What are the clinical features? How do you identify this, that this is present? Your patient of anuria would be running high-grade fever, mostly with rigors, and he would be in a state of shock, hypotension with bounding pulse, and this is called warm shock. The investigation wise, you should do total counts and you will find leukocytosis, polymorpholeukocytosis. You should do in these patients blood culture and sensitivity. The third killer is a fluid overload situation, the clinical features of which are edema on the face and limbs. Patient will be orthopneic, he will be having hypertension, his JVP, jugular venous pressure, may be raised, and you will find basal clefts in lungs on auscultation. So fluid overload can be very easily clinically diagnosed on the basis of these common physical findings. And investigation wise, the best thing is to do central venous pressure monitoring, and you should also do a chest X-ray which will show you basal congestion. Having known these killers and having identified whether they exist or they do not exist in this given clinical case, hyperkalemia is the first killer to be handled with care. I suggest if you have hyperkalemia, push in 10 ml of 10% calcium gluconate. This stabilizes the myocardium against the cardiac effects of hyperkalemia. You do ECG. Sometimes you detect that with ECG you notice reversal of the ECG changes. If that does not happen, you start glucose insulin drip, 20 or 50 gram of glucose mixed with 10-20 units of insulin and run in. Or if you are taking time in arranging that, you push in sodium bicarbonate injections. Or some places you can give nebulized vitamin B2 agonists. Most popular is to use soda bicarb injection. This allows shifting of potassium inside the cells. Having done that, monitor the response again. What has happened to ECG? Have the hyperkalemia signs reversed? If still they have not reversed, this is a bad situation. If they have not reversed, even with that, this happens in very, very refractory cases. If that is the situation, I think best option is to go for dialysis. Diuretics and cation resins, although mentioned in literature and books, I don't think they will be helpful at this point of time because the patient is really very sick. You keep giving him more calcium gluconate, more glucose insulin, more soda bicarb, and shift him for urgent dialysis. You need to remove excess potassium ion from his body. If he is having sepsis, this is also a strong killer. Lose no opportunity for giving broad spectrum antibiotics. Obviously you should take sample for culture sensitivity, urine as well as blood, but then start broad spectrum antibiotics without wasting time. And the choice should be for non-nephrotoxic medications. If you are suspecting anuria and infection of slightly long duration, you may think about giving antibiotics against anaerobes. The third killer is fluid overload, and if it is due to renal factors, then you can try giving them diuretics. But if it is due to obstructive factor, as you will understand shortly, then in a situation of obstruction, trying to give diuretics, it doesn't work. So patient should here be subjected to dialysis. Hemodialysis is of course better, but if you do not have a vacancy in the busy hemodialysis unit, you can initiate peritoneal dialysis, and that's very effective in treating fluid overload. So the point I'm trying to make, that in a victim of anuria, as soon as you decide that your patient is having anuria, take no time in identifying these killers: hyperkalemia, sepsis and fluid overload. If they are present, please be quick in treating them so that your patient is alive. If they are not present, then you have time and you think about what is the cause of anuria and move to this step 3. There may be a perirenal cause like acute hypovolemia. That's the most common cause. And in that patient, you can have variety of problems, variety of things which can lead to volume depletion and renal hypoperfusion and oligoanuria. And I cited here some of the common examples of acute volume depletion. You can have low cardiac output. Suddenly something goes wrong with the heart and heart stops or heart loses its pumping capabilities because of many factors, and the cardiac output drops down suddenly, renal perfusion drops down suddenly, and you can have oligoanuria. You can also have conditions where you have an altered ratio of renal perfusion vis-a-vis systemic perfusion. If you have a condition of systemic vasodilation in sepsis or in anaphylaxis or in a snake bite, so suddenly the blood will pool in the peripheral extremity and the abdominal viscera is deprived of blood flow and you have renal hypoperfusion. Similarly, in hepatorenal syndrome or in conditions of acute renal vasoconstriction, you can have these issues. The next condition is what's called intrinsic renal. That means there's a disease inside the kidney which can operate either at the level of blood supply of the kidney or the small vessels that are present in the kidney. This is called renovascular issue, renovascular problem. There can be obstruction in the renal artery on account of rupture of the atheromatous plaque. There can be acute thrombosis, there can be an embolism, or in case of renal vein, again you can have acute thrombosis or some kind of compression. So whatever it is, if it is happening on an acute setting, it can lead to reduction in the renal blood flow. You can have problems at the level of the glomeruli, which suddenly swell up, like in condition of rapidly progressive glomerulonephritis, or there are conditions like preeclampsia, malignant hypertension, or other conditions where the renal microvasculature is involved or the glomeruli are involved and patient is not able to do renal excretion. Further down below the glomeruli, you can have problem in the tubules on account of ischemia or on account of toxin exposure from outside the body like radio contrast or organic solvents, or from inside the body as in case of myoglobinuria, hemoglobinuria, multiple myeloma. Now these are endogenous toxins and they can create situation of acute tubular necrosis. The tubules get acutely obstructed and patient stops producing urine. Finally, you can have conditions which block the tubules. Nothing wrong with the tubular cell, but there is a wrong with the lumen of the tubule, and you can have crystals of uric acid, you can have multiple myeloma, or you can have drug-induced situation of intertubular obstruction. So the point I'm trying to make, in the kidney, just keep in mind renal vasculature, big one, microvasculature, glomeruli, tubules, and inside the tubules. You can have a systematic approach to renal causes of anuria. Remember these 4 levels and you would know what is happening. or what is likely to happen. The post-renal is the one about which we are concerned. This is the area which we handle when we have acute obstruction either to both the ureters or to a unilateral ureter in a case of a solitary functioning kidney. Patient come to us with acute anuria. The commonest cause of anuria is a stone which causes obstruction to the ureter and produces calculous anuria. Instead of calculus, we have sometimes seen sloughed papillae, sometimes we have seen fungal balls, right? Sometimes we have seen blood clots, tumor fragments. So you can have something within the lumen of the ureter which is blocking the ureter. You can have problem in the wall of the ureter, a stricture which was causing initially partial obstruction, but something goes wrong, some infection occurs, some edema occurs, and the wall gets edematous, and suddenly you get on top of partial obstruction, you get acute untotal type, acute obstruction on the face of partial obstruction, and patient gets anuria. You can have extramural disease outside the wall of ureter, like a mass in retroperitoneum, a vascular compression on the ureter, a fibrotic band of retroperitoneal fibrosis, which are kinking the ureters. So all these diseases come and patients can have anuria. And I must confess that the commonest here is calculous anuria. How do you then diagnose this? Whether the patient is having pre-renal, renal or post-renal? You have to immediately order blood biochemistry, look into serum creatinine, blood urea nitrogen, sodium and potassium. Immediately order for a renal or a KUB ultrasound. If you discover that there is hydroureteronephrosis, this becomes a case of post-renal anuria. Okay? If you say, or if you think, or the radiologist tells you there is no hydroureteronephrosis, and then this may be a case of pre-renal anuria, or this may be a case of intrinsic renal anuria, and you can know about this by further workup. What further workup? This further workup is essentially biochemical tests on blood and urine. You have to find out a ratio between blood urea nitrogen and serum creatinine. You have to find out urinary spot sodium. You have to find out about osmolality of urine, and you have to find out fractional excretion of sodium, and you have to also look into the urinary sediments. And on the basis of these blood and urine investigations, you would be in a position to decide what the patient is having. And then you have to manage anuria as per the cause. The pre-renal anuria, the sheet anchor of therapy is built up the blood pressure. Increased renal perfusion. We were giving dopamine, but of late there's some controversy about this drug. Think about what you can do to improve renal perfusion by drugs, or if there's a reason to believe that the renal perfusion is dropped because of renal arterial thrombosis, then you can ask your interventional radiology colleague to look into this and restore the renal perfusion. So pre-renal anurias are easy to treat. Intrinsic renal anuria requires hemodialysis. Now, till the time the disease in the kidney is settling by your medical therapy, which is steroid is a sheet anchor of medical therapy to reduce the edema of the glomeruli and to reduce the edema in the tubules. Till the time that is showing its effect, you have the patient on hemodialysis, and sometimes when you think tubules are being blocked, you may use diuretics to flush the tubules. Post-renal anuria requires your attempt to relieve the obstruction, and that is where we come into play as urologists. In post-renal anuria, we think of stones as culprit if anuria is co-associated with flank pain with or without history of fever. Such as here, both the ureters are blocked by the stone, and proximal hydroureteronephrosis is seen on ultrasound. So one solution to this problem is that cystoscopically you look for the ureteric orifice and on the side of a kidney which you think may be better functioning. How do you think that? Look into the ultrasound picture. That kidney which has good parenchymal thickness, that kidney which has sort of a rather not very echogenic parenchyma, there you pass the ureteric catheter. The moment the catheter goes across the stone, there is a hydronephrotic drip from the ureteric catheter. The second solution may be, instead of this ureteric catheter which gives you an external drainage, you may make an indwelling internal drainage between the kidney and the bladder, and that's the device, the DJ stent, that is put in. Good device to decompress the kidney on emergency basis. This procedure can be done under local anesthesia also. Or if you think that you are not able to pass a DJ stent because of a lot of edema in the ureter, a lot of infection at the site of stone, or else the obstructed kidney is showing signs of infection, the third solution may be doing a percutaneous nephrostomy on one side, on the side where you think there is infection. Or else you can combine the procedure. One side put double J stent, or the other side do a percutaneous nephrostomy. Or you can do a percutaneous nephrostomy on both sides. So friends, what I am trying to say, you have many solutions to this problem. You have many ways to deobstruct the kidney. How do you do what? How do you decide which one to do? I would personally prefer a retrograde decompression if there is no infection in the kidney. Draining externally is done if you do not have a DJ stent and you want to drain the kidney for a short time. You use DJ stent if you want to drain the kidney for a longer period of time, right? But then the bottom line is, use this retrograde decompression when there is obstruction without infection. If the patient is having a situation where your retrograde attempt fails, then you have to do a percutaneous nephrostomy. Also, if there is obstruction with infection, my choice would be to do a percutaneous nephrostomy, not double J stenting. So in presence of infection is a major determinant of your selection of the approach to decompress the kidney. Say for example here, this is a 32-year male who presented with bilateral flank pain and anuria for last 48 hours. He was not febrile, he was not in a state of fluid overload, he was not having hyperkalemia either. His plain X-ray shows bilateral stones in the upper ureter blocking the ureter. What would you do? He is not dying of any of the problems, potassium overload or fluid overload or infection. So now you know the cause, it's calculus anuria. So you have to decompress. The patient underwent bilateral double J stenting to relieve the obstruction. This patient who had bilateral upper ureteric stones also had infection. He was a diabetic. So then this patient requires a percutaneous nephrostomy on either side instead of double J stent, and that's the placement of PCN tubes. Another patient who has obstruction in kidney on one side and obstruction in the ureter on the other side, he undergoes PCN on the side which is infected and a ureteric catheterization on the side which is not infected. So the point I am trying to make to you, that do something by virtue of which the obstruction is relieved. Once the obstruction is relieved, your patient will go in a state of post-obstructive diuresis. This means that because there is a high nitrogenous load in the body, there is a high acid load in the body, there is a state of sodium retention. The moment the obstruction is released, all these things come in the urine and the osmotic concentration of urine increases, and this leads to obligatory diuresis. And this diuresis, which may sometimes run in many liters per day, 4 liters, 5 liters, 6 liters per day. This depends upon the duration of anuria This depends upon the quantum of nitrogenous overload. And this obligatory diuresis can make your patient hyponatremic and he becomes stuporous and comatose. So please be careful. Higher the nitrogenous load, longer the duration of diuresis. Greater is the quantum of infection, longer does it take to recover. Remember these two lines when you are managing anuria. And finally, step, prevent recurrence. This means that whatever cause you discovered as a cause of anuria, it must be treated. Definitively, a stone must be removed, malignant masses must be removed, and anuria must be treated. Thank you very much for watching this presentation, and I expect you will have questions and you send them to me on my email. Thank you very much.